52-page course pack, which I'm sure is going to collect and have enough information in there to keep you busy for a while. I do want to also talk about the scope limitations and potential issues that may come up today for you. There are topics that are not going to be covered. It's a huge topic. One, I'm not going to be going into treatment planning. However, in your course pack, there's a ton of information on treatment planning to help you out with that. To treatment of prolonged grief disorder, I will be introducing the concept and the definition of prolonged grief disorder. Again, additional information on how to work with prolonged grief disorder is available. However, that does require extensive training, so it is very limited in your course pack. I am not going to be covering therapy for couples and families who are impacted by traumatic grief. As important as ethical considerations are in when we are doing work with grief and trauma, again, they're covered in the course pack, but I just want to make it very clear that there's not like an entire section on ethics and dying trajectories. Again, this is more about traumatic grief, not that a dying trajectory can't be traumatic, but we only have so many hours in the day. There are some potential issues I want you to be aware of. Look, you may experience some personal reactions to some of these ideas, information and concepts that are based on your own traumatic grief experiences or processes. I bet if I asked every single one of you how many of you have expected or have experienced some kind of death or non-death related loss, without a doubt, every single person would raise his or her their hands. Uh, in terms of traumatic grief, I bet you could nail that down too. So I just want you to be aware. And in that case, I'm going to ask you, please take care of yourself. If you need to walk away for a few moments, just to kind of take a breath and make it so that you're in a present place, please do not hesitate to do that because you have to be your priority. You may find that you are reflecting on your past, current, and future work with bereft clients. So you may find that you're going, oh, wait, I could do that with this current client, or oh, when I was working with that client before. Look, we are all on a learning trajectory. I hope that we would open ourselves up to continuing education of any kind of topics that would expand our clinical skills. So I'm going to ask you to be graceful with yourself. If you have experience like where you're listening, you're like, oh, I missed that. It's okay. Or man, I nailed it, man. Give yourself some credit. So again, I hope today that you will leave with some concrete ideas of what you want to do with your clients, but even more specifically, what is going on with your clients if you're working in that kind of setting. All right.
Lizzie,
Hopefully you have a yes, yes.
wait, I think you see you need to reshare your screen. We don't see any slides right now.
Has it not been showing up at all?
Not yet, yes.
Oh, goodness gracious. All right. Well,
And then click share sound.
it's not giving me. Okay, hold on.
We have it now. Okay.
Click share sound. I
I
see a
think
lot
we
of.
were, yeah.
Is that now
Did you click
showing?
share sound when you shared?
Pardon me?
Did you click share sound before you shared?
It did not give me that option. I'd have to go out. This. Do you want me to go out and make sure?
Yeah.
Okay.
Thank
Bear with
you.
us. Yeah. Hang on.
A lot of thumbs ups here.
Yeah, there's going to be there's a video, and that's why we're asking for sharing sound. Okay, let me just close that out then real quick and see if I can open that back up. Not sure what happened there. Can you hear me?
Yes, we do.
Okay, at least I didn't get out of Zoom. All right.
Yeah, still
Oh,
good.
there's good. Yeah, you can hear me, but I'm worried about whether or not you're going to hear the audio, and that's not giving me a chance to.
When you click share, there should be a pop-up window and then share sound at the right.
Right. Okay. Gotcha. Then let me make this full screen. That's so strange. I wonder what happened there. Yeah, that is shared, in fact.
Yep. And then full screen your slides.
Yeah, I'm gonna full screen the
Okay.
slides.
Okay.
Can we see that?
Yes, we do.
You do. Okay, I see hearts and things and all the things. Okay. So if you have a piece of paper in front of you, and hopefully you do, uh, I'm going to ask you to draw a line. On one side, I want you to write birth, and the other side, I want you to write death. And I would like for you to place an X where you think you are on that continuum. Now, where are you on that continuum? How many of you said, and by clap of hands or fingers or, young adulthood? Okay, I got some people saying young adulthood, a couple, I've got two people in young adulthood. Who else have we got? Okay, excellent. Okay, they're coming in. Now, how many individuals identified in middle adulthood? Lots of fingers. Great. All right, I'll let that go for a second. Okay. And how many people said late adulthood? Should see. I don't know if y'all can see it, but there are so many hands and everything. How many said, I mean, you just didn't know? Okay. So one of the things that I do when I present is I do utilize my own life narrative as a way of connecting not only to you, but to let you know that I'm not just going to come at you theoretically. I'm coming to you from a place of knowing my own story. And the way I got into the field of thanatology was because my brother on Christmas Day in 1999, who was 22 years old, his name was Damien, he died from a drug overdose on Christmas Day. I was 26. You do the math. I'm not doing all that. When I was halfway through my first master's program at that point, and what did I do? I just went ahead and went back to school. But 3 weeks later, my grandfather died. 2 weeks after that, or about a month after that, my mom and my father picked up here from the East Coast and went to the Midwest because they were just so bereft. My mother wanted to go back to her family of origin. And in the interim, that left me with multiple losses in a very short period of time. And we're going to talk as we go along today about some other things that happened. I also am going to share with you case studies. And I think that's really important. But I bring up this question about where are you on the continuum, not to be morbid, but to ask you, how do you know you're not right there? Damien was 22. I'm sure many of you have either worked with people who have lost individuals who are young in their lives, and it feels like it's outside of what we would consider the quote unquote normal trajectory. But that's the reality, especially with traumatic grief. It feels like it's just not in this normal trajectory in an industrialized country, right? If we were in a non-industrialized country, it may feel a little bit different. So I ask you this question because if there's going to be anything that is going to bring up any kind of countertransference, any of your own feelings, it's going to be working with people with grief and trauma. I don't know about you. I did not have a required course in graduate school in death, loss, and grief. I had an elective. Maybe it was part of an aging course or something like that. But I didn't have a class. And yet every single person you work with has had to experience grief, non-death or death-related losses. And it has flipped their narrative. So we're going to talk about that. Not only the flipping of the narrative, but the blowing up of the narrative when you add a traumatic experience. So let's talk a little bit about normative grief. You might have heard this about as uncomplicated grief. But in my opinion, I don't know about you, but I'm going to work with this definition of grief, if you don't mind. It's what we experience, obviously, when something meaningful is taken away or if something ends. It is that inner echo of what it is, the reflection of the connections that we've had in our lives, the assumptive worlds that we have, which we'll talk about here in a second. But it's completely, it's connected to attachment. If you are not attached to something, you won't have a sense of deprivation once that thing or time in your life is gone. So, if you're not familiar with attachment theory and how it relates to grief theory, I'm going to encourage you to take a look at that because it significantly impacts how a person is able to move in their grieving process. So, and I'm going to talk a little bit about indicators of therapy might be ready to close, but I want to explain normative grief to you as well. Look, all grief is complicated, but not all grief is clinically complicated. About 90 to 93% of individuals move forward in their grieving process in a natural, adaptive way. Not everybody needs therapy for grief. Some people may seek out therapy for grief, and that's fantastic. You're there. You can facilitate the grieving process. Did you hear me say facilitate? You're not treating grief. You don't have to use cognitive behavioral therapy for people who are experiencing grief reactions because they're natural adaptive reactions. And we'll get to that a little bit later. What we do know is that those other 7 to 10%, and it depends on your researcher, will potentially move into what we call prolonged grief disorder, which that has a whole history that we won't have time to get into today. That is where specialized techniques come in. And a traumatic loss is a main risk factor for prolonged grief disorder. Now, there's 330 million people in the United States-ish. At any given period of time, about 60% of individuals in the United States are in a bereft state, actively in a grieving state. Now, take 7 to 10% of those individuals and say to yourself, wow, like those are the amount of people that might be going into prolonged grief disorder. We don't have enough people in the mental health field that are able to work with people that are struggling with such an amazingly destructive disorder, one that is shattered so much of their assumptive world. Now, we're going to talk about what exactly I mean by assumptive world, right? Because that sounds, maybe a little bit more vague right now. But my point is, you're here, and thank you for being here. Because there was a part of you that went, you know what? I think I need to know a little bit more about that. And this is me also saying, come to the dark side. Us thanatologists need you to come over here and be with us. So, what we're looking for in the normative grief response is at the beginning of a loss, it may feel very acute. Your psychological, cognitive, emotional, behavioral, your executive functioning, your interpersonal beliefs, your spiritual beliefs, all can become very shattered after a loss. And the intensity of those losses, it's different for different people, for different reasons, for different relationships or different attachment. But usually that there's a pretty acute reaction there where things feel a little bit out of control sometimes. But over time, what we're looking for is a gradual reduction of intensity and duration of those experiences over time. But you have to have spaces for what we call these STUGs, sudden transitory upsurges of grief. The 16th was my father's birthday. I'm going to tell you a little bit of a story about my father and mother here at some point. And I've lost my father in 2024. And then in a few days after that was Father's Day. Not very fun to work my way through. The surge of my grief came out in very unique way. I was very tired. I was irritable. I was having a hard time concentrating. I was fatigued. As I mentioned, I was tired, but then there's like this whole other layer of fatigue. Interpersonally, I found myself wanting to withdraw, and other times I wanted to get close to people. I tried to bury myself in work, and then I was like, well, okay, that's not a, you know, healthy defense mechanism. Let's go garden. Let's go garden, and it's hot as heck. And moving away from that, it's a non-linear grieving process. Now, as much as I would love to go into the different theoretical orientations of grief, I am going to share this with you, and I'm going to say it very clearly. There are no 5 stages of grief. There aren't. That is a theory that's a very old theory. It was based on research from 55 years ago. And there are so many other theoretical orientations, again, covered in your course pack for you. Many, including an integrated approach to it. Even though that 5 stages of grief has been a little tweaked over time, I want you to think about this. If a client believes in 5 stages of grief and one of them is depression, and yet sadness and depression are 2 separate things, then the internalization of this being a depressive state is problematic. They go to their doctor, I'm depressed. Okay, here's an antidepressant. We already know antidepressants do not work on the treatment of grief. Anyway, I'm getting a little off, but I'll get you there. We're just going to take the scenic route. Don't you worry about that. So what ends up becoming frustrating is that in our field, you think our field isn't educated enough about grief? The medical field is truly underserved in terms of receiving that kind of education, which is extremely unfortunate because they are also on the front lines. So what we're looking for is for me to say to you, and if it's ruffling your feathers or you've been working with the 5 stages of grief up until this point, it's totally understandable. That's what we've been training people on. So if we're training current psychologist or any kind of professor, anybody in a training position on the 5 stages of grief, and nobody is expressing the phase, task, attachment theories, rando 6Rs, meaning reconstruction. If we're not teaching those, then that set of individuals is going to pass down, learning theory of the 5 stages of grief. So if that's what you know, I totally get it. It's what I knew at the beginning too. So just so you know, you're here. You can learn more. Okay. Over time, what happens, and you've probably heard this or maybe have experienced yourself, I can't believe he's gone. I just cannot believe he's gone. I still can't accept the fact that he's gone. It's not that we don't know intellectually the person is gone or the event happened. It's that emotional acceptance of the reality of I've accepted the fact that he's gone. And that takes time. And you do not need to challenge that. That will happen naturally and adaptively. There gradually, as a result, over time, the person may be starting to adapt their world to the person, being out of their lives, or the relationship being out of their lives, or the job, whether or not it's voluntary or involuntary, your health. Generally, there's an adaptation to that and growing acceptance of that. Now, not all cultures are open to this idea of a continued bond, and I'll explain this in a little bit, but I think we need to be very careful from an ethical perspective that not only are we culturally aware, but we have the cultural humility to be aware of our own cultural expectations and making sure we're not placing those on top of anybody. Nobody grieves outside of their culture. And we may have the American culture, but there's so many subcultures, right? And then the familial cultures as well. What we do know is that a continued bond with the deceased can be part of the integrated grieving. If you notice, I do not say resolved. I don't know about you. I have never resolved a loss in my entire life. I have integrated that loss into the narrative of my life. I have changed as a result of that. We move forward with our grief. eventually going from being in pain to having our pain. So a continued bond with the deceased is developing an attachment to that with whom or to whom has been lost in our lives. So let's say this is the narrative of your life, okay? I don't know, that's how I can explain it. All of a sudden, a loss happens. Boom. Life just blows up. Well, in that narrative, we have attachment throughout our lives. People, work, spirituality, relationship to nature, music, pets. My three cats are my favorite people in my life who live in this house. I'm looking over there. Let's just make sure nobody else knows that. My favorite people in this house. Losing your animals actually has a huge impact on individuals that we often can can disenfranchise, which we will talk about a little bit later. So a continued bond with the deceased. There's so many extremely helpful, creative, fun to engage in. I don't mean like grief is fun, but that creativity that can come with interventions with continued bonds with the deceased are an extremely powerful way to help that person weave in that narrative. So that happens over time. Now, let's say that I am married and my wife and I had always believed that in our later years in our lives, we were going to travel all over the place. We had these aspirational goals. And then I lose my wife. Well, what about all that travel? What about all those plans I had? Those are gone. If you're doing grief work with people, not only do you have to grieve what they have lost, but you have to work with them in helping them grieve all of the potential futures that they had, including all the secondary losses that have come as a result. It does not happen in a vacuum. So when all of those life goals, whatever those are, when the life goals have no longer held the same value because they cannot be utilized or connected to or attained, the person that you're working with must reconsider what their future will look like now and what kind of life goals are going to be redefined and where's that energy going to come from to do that. So there is that gradual return of their energy and reinvestments into people, activities, relationships, etc. It is so natural for us to have if onlys. If only I'd spoken to him more. My in December of 2023, I was diagnosed with leukemia. And I was my mother and my father just happened to be there because I had a knee replacement, and 4 days later I was told you've got leukemia, and went into the hospital for a month. Couldn't even come out. I'm rehabbing my own knee. My parents are there. Goodness knows all of my friends were there. But my parents were there. Mind you, they lived in the Midwest. They came out to take care of me for my knee replacement. And now I'm in a hospital and they can't do anything except be with me, which was powerful. I remember my father and mom coming to me and saying, "Hey, we were here to try to take care of you with your knee replacement. We want to be here, but you're going to be here for a month. How do you feel about us heading back home?" 5 months later, my dog dies. 3 months later, my dad falls down his basement stairs and he dies in my mom's arms. Talk about a traumatic loss. I fly out. I'm with my mom, still very much into my chemo treatment. I leave saying, "I'll be back, Mom, in a week." And the day after I landed, she died. She died in her bed. And I can hear a lot of people, broken heart. Yeah, at least she didn't suffer. Don't say that. At least she's with him. Don't say that. She should be here, kind of thing. So 2024 can suck it. With that said, the if onlys that play in my head was if only I had gone to see them a little bit more. But I was too sick to do that. If only I had said, can you stay a couple more days? I would have had some more time with my dad. So here's my stug that I'm sharing with you today, even just talking about it. And as important as this work is, as part of the meaning making in my work, I will always carry that with me. So, how you imagine as a clinician, because I am an active clinician, I do see clients, when I have a person across from me who has just lost her father or her mother, my own crap comes up. I'm aware of it. That's important. Consulting is aware of it. But you've all had losses. Y'all get triggered. Y'all get triggered. My husband and I we just got a house in West Virginia outside of Harper's Ferry, and all of a sudden I'm starting to use y'all while I'm living in Delaware. It's quite interesting. And humor, by the way, and intellectualization are great defense mechanisms when you're feeling a certain way. All right. And then we have meaning reconstruction. We're going to talk more about meaning reconstruction as we're moving throughout the day. We have to. There's no way of navigating the grieving process, especially a traumatic grieving process, without feeling like, how are we going to make sense of what happened? How am I going to reconstruct who I am in the world? And perhaps there is some post-traumatic growth, which is what we're looking for, or post-loss growth. So yes, I spent a lot of time on the slide, but I want to let you know where I'm coming from when I'm talking about integrative grief, integrated grief. So this is just a little slide to kind of sum that up for you. All right. I'm not saying anything there any different. We do have those bittersweet memories that come up. Oh, I remember that one, uh, time that I was uh, sledding with my sister. I'll never forget that day. Example of that. Okay, so what do I mean by assumptive world? I've said it a few times. So what exactly am I meaning by that? This is the way that we interpret the world and the events that we have to try to make sense of who we are in the world through that. It gives you a sense of predictability, consistency, and safety, even on a daily, on a in a daily process. Some look on a daily basis. Ha, there it was. It's how we view the world, ourselves, and that usually forms when we're very young. And as you can imagine, many of you are very familiar with as children, we have learned about attachment and we have learned about what is safe. And if you've had an abusive childhood, and perhaps there's some complex PTSD where there's developmental trauma, your assumptive world might be a little wobbly, very painful. But as you can imagine, as there is a loss, the assumptive world doesn't make sense anymore. Who am I now? Whose am I now? I've sat across this table from this person having a cup of coffee for the last 15 years of my life. And that, so many of you had said, hey, my morning coffee. What if that was gone? That thing you wouldn't give up for anything? What if it was gone? This helps us figure out where we're going to start making choices from, how we form our relationships with individuals, how we form our belief systems, secularly and maybe even spiritually, if that's something that's in your wheelhouse, about how we should act. So this assumptive world, what else does it include? How you find safety in the world, how you believe things should happen, the belief in how things work, how you view yourself, and how you fit into your social environment. Now imagine a loss. And I mean, not only on an individual level, but on a cultural level as well. An example would be, what about 9/11? If you were alive during that time, because some of you weren't, you saw how the world, I mean, My God, everything about our assumptive world of being safe. We lost our sense of safety. That is a non-death related loss. That is not how things are supposed to work. We've got a lot of socio-political grief now. I'm not going to go into, politics, but we clearly have a lot of unrest right now. And that is shattering our assumptive world. How you understand yourself in this new shattered assumptive world that requires the work of being able to pull those pieces back together, to weave them back into who am I now and what does my world look like now. So you might imagine you're right here in the middle and you've got all these things that are part of your assumptive world. Well, one, two, or three things in that assumptive world are gone. That structure, no, it doesn't work anymore, right? You have to figure out how the pieces of your puzzle then look. And then again, we'll come back to meaning reconstruction. Now, there are definitions of different kinds of loss, and I want to be sensitive to that. There's what we call a non-finite loss. What's the definition of that? This is obviously an ongoing, enduring loss where it doesn't seem like there is any kind of endpoint. So, for example, any chronic conditions or any life limitations, it's where grief is constantly being renewed. So how are you integrating a loss if there's there's no place where you can say, okay, I have grieved that loss and I'm grieving that loss. And this is the event that happened. This is not about an event that happened. This is about something that happened and is continuing to happen. And there's perpetual grief that is occurring along the way. It evolves over time and therefore begins to unfortunately impact normal development and gets in the way of potentially meeting those life expectations. What if it's your own chronic condition? It leads to other types of secondary losses, which we've talked about, and intangible losses. For example, a loss of safety, the loss of a potential, the loss of, do I make those plans? Am I going to be alive to do that? So what are some characteristics? And again, these are expanded in your course pack. There's no single moment of loss, as I've mentioned, and it continues to unfold. It is triggered by milestones. We all have stugs. We all have sudden transitory upsurges of grief. Pick a holiday, pick a birthday, pick the day of the passing, pick the day of your retirement, pick the day of your diagnosis. Pick the fact that you're driving next to a blue car and your brother used to drive a blue car. It resurfaces, especially during developmental transitions. And this is an important concept to carry with you because if there has been a traumatic experience, but yet that person has not passed, for example, and they are in a chronic condition that is now different than what it was before they were in that event, that person may be carrying a sense of chronic sorrow. You're not going to fix that. There is no fixing grief. It's going to be more about how am I going to live with this as I continue to live in my new assumptive world. This is a recurring sadness tied not only to what happened, but what might have been. And there's no closure. Loss is never fully over anyway, but I think you know where I'm going. The adaptation requires a person to live with the loss rather than resolving it. This happens a lot with caregivers. I don't know how many of you are caregivers or have worked with people who are caregivers or work in hospice or work in, certain positions where I see a lot of thumbs up. Yep. I don't know about you, but I remember my grandmother, she had Alzheimer's and my mom was her caregiver. That's a chronic sorrow as you watch the person that you had in your life chip away. I had a client once say to me, I lost my mother one chip away at a time. You lose the person who was in your life before the person actually has passed. And that's heart-wrenching. So now when we talk about traumatic grief, we're going to take it a whole nother level, and that's what you're here for. Okay. The video that I'm getting ready to show you here shortly is from Dr. Ted Raniерson, who is he's not the only person, obviously, who researched this starting in the 70s, but he is, and he's been around a long time. So he has, you'll see when he's presenting, he is a really cool guy. I met him in person. And he was on my podcast, and I had the opportunity to interview him. And he's going to talk about traumatic grief because he is one of the foremost pioneers in this field in the research. So here you go.
Nightmares, flashbacks, panic attacks versus the other image of sadness and solace, which at least is associated with separation and comforting. And you want that back to remember that sort of imagery so that there are opposite sort of dynamics going on, psychodynamics, which are related to the adjustment to what's happened more than anything unconscious or any models of disorder, psychological disorder. What's disordering is what's happened.
Right. So you have this push and you have this pull. And I think I'm hearing you say that there's, because of that visual, and since we are characters and creators of our narrative, we want to fill in the blanks. Like, was she scared? You know.
You don't have any choice, and you can't.
Right.
I mean, that's
Right.
using the dying imagery is you try and form a narrative around that. It's particularly after a homicide.
Mm-hmm.
It's impossible to find any meaningful narrative about that because of what I call the 3 V's: violence, violation, and volition. Violence meaning that the dying itself is external. It's often mutilative if there's been an accident or a homicide.
Mm-hmm.
Sometimes with suicide, with men that have shot themselves. So that there's this image of physical damage, horrific often. So violence, which is associated with PTSD sort of signs and symptoms. The violation is associated with victimization. After a homicide or an accidental dying, you're left with the victim sort of identity that the deceased was never able to go through themselves. But that's part of the legacy, is feeling victimized as an after effect. And you see that very frequently, particularly after there's been a homicide and all of the investigation that goes on and trial that goes on. This is really emphasized with that kind of violent death, not with suicide. When the police handed me my wife's suicide note about a month or 6 weeks after her death, there wasn't anything outside me that was going to go through the end, who was responsible and who's going to be punished, and which goes on, I think, after accidental dying or homicidal dying.
Mm-hmm.
I think I was left with the lonely sort of inquest that I had to go through myself. There wasn't anyone there. And of course, it is lonely. I mean, there isn't anybody outside that's going to help with that, other than listening,
Right,
and helping people to become more capacious with this sort of imagery, so that it begins to belong to them by being able to retell it. And I think that's an important part of adaptation after any kind of death, but particularly after a violent dying is what's gone on for thousands of years. When there's a death, and people get together to memorialize the image, the attachment image of the person that's died. And I think just by being able to be open and a gentle sort of exposure to the way of the dying, to the dying narratives, and they have given an opportunity to. A significant number of people avoid all this, particularly in our culture. And avoidance is important to respect. And it's not a good idea to obviously put people in a position of beginning to give up some of this avoidance until you have a relationship with them, and they have something better psychologically to replace it with, which is, I think, somebody going through this conversation with them. There isn't any medicine that's going to help with this. We know that grief does not respond to any kind of medication. So I think part of what goes on, particularly in dealing with violent dying, is dealing with the imagery through groups. I think group psychotherapy is the most effective way of treating this. So a number of people individually as well. I think in a group setting, there's enough resonance and echoing to heighten not only acceptance of what's happened and retelling and beginning to moderate each other's stories. The group, I think, provides an opportunity for people to take care of one another, which doesn't go on in individual therapy. And I think it's an important resource of resilience.
Yeah.
You know, I noted early on in terms of taking care of my kids was a way also of taking care of myself, finding meaning. And I think that goes on in group much more than it does with individual therapy. And in that sort of setting, you can set up sessions of memorializing the person, bringing them back to life with images, with pictures that they bring in, sometimes food, sometimes the things that the person has written, sometimes videos, and then also introduce after that, which is a stabilizing sort of narrative, to give people the opportunity to also expose themselves to the dying act itself, often through images, drawings, which kids do, I think, reflexively. And my work with Bob Heinens and other people, I've been persuaded that that's important to do with adults as well. They haven't been able to express any of this in words to begin with images, because that's what they're left with. Even stick figures, to begin introducing the person that died. If his name was Fred, and we're setting up something triadic as we're looking at the image. How would Fred feel about your telling the story? Where would Fred want you to be? So somehow introducing the other person as an ally, person that's died. So there's something triadic that begins to go on with the work. This is all shamanic in terms of not only visiting the scene, but visiting the soul of the person to reestablish some sort of balance because of the distressing way that they died. They are left with the distress that the person was never able to work out themselves. And I recognize this in myself because you remember Bainbridge Island. It's on the ocean. And if this had died, if she had died 1,000 years ago, and I was a member of the indigenous tribe, there would have been a shaman who would have helped me. And the shaman who would have been a woman, most of them were, would have gone through this sort of ritual that I'm talking about. Not only communicating with me, but communicating with the person that had died through a ritual, shamanic sort of connection. I think the same thing to some extent goes on with clergy and religion.
So, please excuse the kind of quality of that video. He mentioned Bainbridge Island. He lives on Bainbridge Island. There is no internet on Bainbridge Island. But more importantly was what exactly he had to say. And I thought it was really powerful and wanted to share it with you. And I didn't want to give it to you from anybody other than somebody who knows it way better than I ever will. So, and also I'll be pausing maybe about like our first break is 11:30. I'm probably going to pause at like 11:20 and answer any questions you might have because I'm seeing that the question and answer section is on fire over there. So I'm not ignoring you. I just want to let you know I'll come back to it. With this many people, we'll need a little
Nightmare.
time. Okay, so this is me just kind of summing it up, that definition of traumatic grief, which is that combination of bereavement and trauma following an unnatural death or an assault of some sort. He talked about the intrusive traumatic imagery. I didn't see my father die, but I see it in my head. I see my mom holding him. That's intrusive. That pops into my mind. Your clients who've had experiences with some kind of assault growing up, some kind of event that has happened, those are popping into their heads at times where it's like, where did that come from? And then there's a hyper arousal, which is why we do some somatic work when we're working with clients with traumatic grief, because they are struggling with being able to integrate that loss and to sustain that bond, which is just what Dr. Renierson was talking about. So he talked about the 3 V's, and if you wanted it in writing, there you go. But again, like acts, violence, violation, and volition. So traumatic loss can take a lot of different forms. It can be sudden and unexpected, like accidents or like medical events, for example, violent and intentional, such as suicide or even homicide. They can be prolonged in medical trauma. I can't even right now. If I had one, I just did one of my podcasts was on medical trauma, the whole podcast, and working with somebody who worked with a lot of medical trauma. And I just out of question for you, and certainly I can't see who you are, but how many of you have experienced some form of medical trauma? By show of hands, heart, finger. Yep. Look at this. Whoo! I'm not sure if you all can see it, but there are hundreds. How are we not talking about this? So we're talking about it. We're talking about it now. So chronic illnesses, multiple sclerosis. I mean, well, we can just go on. Epilepsy. I have epilepsy. That's something I have a lot of trauma around. How many clients? Long COVID, where we're gaslit into thinking that there is no long COVID. There is long COVID. I'm telling you, I've seen it. Caregiving or any kind of anticipatory losses. And then we have the collective and large scale types of traumatic losses like natural disasters, community, excuse me, or mass trauma. I mean, we certainly have been seeing that a lot in our culture right now, right? So each one of those carry different themes: guilt, fear, helplessness, maybe fatigue or prolonged exhaustion, and more. So what are some of the key features that we see when we're talking about traumatic grief? That intrusive memory and maybe even re-experiencing it. I don't know how many of you know, for example, Janina Fisher or Anderson. Oh my goodness, his first name. Brain's not working. Frank Anderson, Bessel van der Kolk. These are all familiar to you, I'm absolutely sure. We do carry emotions in our body. We think them and then we carry them in our body. That's why when we do therapy, not only are we doing top down where we talk about what's going on, but we're doing bottom up. If you want to get integrative, become familiar with how to do bottom up processing, bottom up therapy, EMDR, somatic re-experiencing. And finding a way to merge the two becomes very integrative, not eclectic, integrative, big difference. So in working with people who are re-experiencing that, for them to be able to identify where are they experiencing it. I don't ask people, where do you feel it in your body? I say, where are you experiencing that? That's different, because then we can explore the experience of it. Avoidance, as we've talked about, which unfortunately can lend itself to prolonged grief disorder, because prolonged grief disorder, one of the two main diagnostic criteria can be avoidance of what has happened. So we want to look at avoidance and the issues around that. Hyperarousal, so high anxiety, which again can it be diagnosed? Sure. Is it really part of the diagnosis of a generalized anxiety disorder, or is it part of actually a traumatic grief or chronic PTSD? You as clinician, you're the ones that have that clinical knowledge. But flashbacks, panic attacks, startle responses, starting to sound like PTSD, right? Disrupted attachment bonds. So with that difficulty of recalling those positive memories with the person that we have lost, that bond with the deceased is now overshadowed by what happened. And one thing when I'm working with people, when we talk about these attachment bonds and other kinds of losses, when I get a lot of if onlys, which is normal, again, if onlys are normal, or what ifs, we talk a bit about, did the relationship, was that completely defined by that one final moment? Or are we able to expand and look at the entire breadth of that relationship? Is that moment of that traumatic death overshadowing your ability to experience the fullness of that relationship? And that inhibited mourning. So that the trauma is dominating. And so it may push aside meaning making and integration of that loss even more difficult, further away. Now, I am going to talk about disenfranchised grief. Look, if there's one thing you're leaving with here in these hours that we have together, if disenfranchised grief is it, I am a happy woman, because this happens all the time and people do it to themselves and we do that to other people. And it usually comes from a place of wanting to help people, but unfortunately it can backfire, significantly backfire. Now, before I go into this section, I'm kind of curious, because I have examples of this that I bring about my family, and I got to make sure that I'm able to use the same jokes. Have any of you ever attended to any of my trainings before in any way? Oh, okay, I got one. Two. Oh boy. All right. Well, A, I'm so glad you're here. B, oh my goodness, many. I'm going to use the same jokes anyway. Just bear with me. All right. Disenfranchised grief. What is the definition of that? This is when a person is denied the social support that they need to heal. You know, there's a saying that says, joy shared is joy doubled, but grief shared is grief halved. We are not meant to grieve in isolation. We are going to have moments of being alone with our grief. But when a society says, you know, you're being denied the right to grieve and the social support you need in order to heal, and you're not being socially validated, where does that put you? Well, it falls into 5 different categories. And look, when you are looking at disenfranchised grief and you're going, hey, you know, if you were in front of me, I'd be asking you, okay, well, give me some examples of these things. You may pick a type of loss and it seems like it could fit into multiple categories. I don't care about what category you choose. What I care about is whether or not you're aware of those categories. And it falls into multiple categories, fine. Maybe it has privilege into one of these other categories. Neither here nor there. I just want to make sure that you can see where it's coming from. So the first category is that, and this comes from Ken Doka, who's done a tremendous amount of work on disenfranchised grief, especially starting in the 1990s. The significance of the relationship is rejected, minimized, or not even recognized. So examples of this would be people in the LGBTQ population. Interesting month to be talking about that, right? Or it's minimized, caregivers. Or how about this? Ex-spouses. When my mother-in-law died, my father-in-law, they were divorced, came to the funeral, the viewing and then the funeral. It was not a very good breakup, let's just say. The relationship was very fraught with a lot of difficulties. So he actually sat in the back of the church, and I could hear people, they had lots to say about that. So I went back there and I was like, hey, how are you doing? And he was kind of like, I mean, it's a strange question to ask, but yeah, nonetheless, how are you doing? I was like, kind of damned if you do or damned if you don't, right? And he goes, exactly. And I said, well, I'm glad that you're here, and you'd be here as long as you need to be here. That was my response to that. What if the person is having an extramarital affair? Another example. An abortion, a miscarriage. I mean, think about all the women's reproductive rights being argued right now and what's going on with there, the significance of the relationships, not only of the people with whom we've had connection to, or maybe even the loss isn't being recognized. So I'll give you an example of this, and when loss is not recognized because the loss is non-human, abstract, or inanimate. Research hands down shows that the loss of a pet can be just as painful and disorganizing as the loss of an individual. We know people who have pets actually live longer than people who do not have pets in their later years. It's also plants, interestingly enough. I'm glad they're not. I have one plant. He's hung in there. I don't know how. I'm looking at him. Like you can see him. He's there. I'm wishing him love. Abstract losses, safety, health, job, home, milestones, the empty nest, marriage, partnership, inanimate losses. We don't pick up on those. We don't pick up on them all the time. How about the griever is not recognized as being capable of actually forming relationships? You know who falls in here a lot? Children. Now I don't treat young children, but we make a lot of assumptions, or clients may make a lot of assumptions, because I bet if I asked you how many of you are working with kids, I'd see a lot of fingers and, thumbs and that kind of thing. The griever is not recognized as being capable of actually experiencing grief. Well, hands down, we know 100%, yes, children do in fact experience grief. They just do it in a different way. It's based on their cognitive development. If you want to know more, because I don't jump into talking about traumatic grief with children too much, look into what is called a death construct theory. I'll say it one more time. Death construct theory. It's a wonderful thing to know, not only as a clinician, but just as an individual, and to be able to work with the adults in a child's life. They experience and express their loss through play, behavior, and art. Play, behavior, and art. So think about what it would be like to have somebody, oh, I've got an example for you, a clinical example. I change things just, clinically, just so for confidentiality. I have a client that I'm working with who has experienced a recent loss, and we've been looking at what I call the loss line. When did losses start? What did you learn? How was it handled in your family, et cetera, et cetera. So he was talking about how when his family was moving, after he was living in a home he felt very safe and loved in, he hid behind the couch because he was afraid they were going to pick up and move him too, and he didn't know to where. And he was terrified, and he was avoiding it. Avoiding, the people. Nobody explained to him, we are going to move to another house. You're going to have a new room. You're going to have the same pillow. We promise you, you'll have the same bed. And this is what you can expect. He was 3 years old. That's how impactful this was for him. So as we've been going through his loss line, we're identifying the way that he survived brilliantly as a child, brilliantly, was to avoid. That we have a survival skills that we all use. His was avoidance. He didn't have power. Well, that pattern of utilizing avoidance when he is in a situation in which he is feeling pain or experiencing grief or anticipatory loss has regressed back to avoidance. Understandably, it worked. Why wouldn't you do that? I never pathologize that. Is that working for you now? That's an important question. How is this working for you now? People with intellectual disabilities, people who have some form of dementia fall into these categories. We make a lot of assumptions. The circumstances of the death or the loss was stigmatized. Suicide, homicide, AIDS. For a while there was COVID, but well, that's a whole nother thing. Drug overdose, gang violence. Examples of that. And the grieving style is unacceptable. Now, this can fall on multiple categories. One is obviously the person's grieving style, whether it be very emotionally expressive, whether it be very constricted. Perhaps that's not acceptable, right? Person ends up going back to work and just keeps going on and on and on. Oh, okay, who's to say? I see it in families where maybe the one parent responds to the loss in a different way than the other parent or partner. And I've had clients who have come in and said, he must not have loved our son enough. He just doesn't even express grief. Like it's not even a problem for him. And here I am falling apart and he's not even talking to me about it. And he's going, well, she's falling apart. And I feel like that's really overwhelming. And she's just not allowing herself to move forward. But, at the same time, she's not recognizing that, yes, in fact, I am grieving. And within family systems, because when you lose one person, everybody in the family has to adjust. And then there's cultural issues around grieving styles. And I'll give you an example from my own life. Half of my family is Italian. The other side is English and Irish. All right. But I grew up that's ethnicity. Culturally, I grew up Italian. My Uncle Sonny died. He was 50 years old. He died on his 50th birthday from a heart attack. Now, this is my dad's aunts and uncles, okay? But that's who I grew up with. Then we have Aunt Franny, Gloria, Dolly, Edie, Marie. Yeah, and Uncle Sonny, somewhere in there. Anyway, nice, German names. When my Uncle Sonny died and we were at the viewing, at the funeral home, we had my dad's side of the family over here, the Italians, and the English-Irish side over here, who did not know each other very well. After Uncle Sonny died, this is what you heard. They're sitting in the middle of the funeral home, and they're going, "Oh my God, God, why did you take him? I don't understand. He was a saint. You should have taken me. Oh, Dolly, he should have taken me. I can't believe he did. I can't believe he's gone already." Certainly bereft, but 2 weeks prior, they probably weren't even speaking to each other. But okay, my Aunt Gloria got up and tried to climb into the coffin. This is a true story. I'm like 15 and I'm like, what the hell is going on? Tries to climb into the coffin. The rest of my Italian family's like, "Oh, Gloria, come here. No, blah, blah, blah." My mother's side of the family was mortified. "Kathy, this is why we told you not to marry this man." Needless to say, that grieving style is unacceptable. When I do an intake, I do not say this person is Caucasian, Asian, Latino, on and on, Black. I don't do that. Dive in. Different cultures, within those cultures, grieve completely different than others. I have a client that came from Sweden. There was no talking about grief. You were like, you got a day, and then off you went, rest of your life. You already heard about my Italian side. So if I'm not diving in to find out what cultural expectations you had, and not only what culture, but how much do you agree with that cultural expectation? How much is that colliding with your family? I had a client whose husband died by suicide. I want you to hear that. I said died by suicide. I didn't say commit suicide. Ask yourself why. Died by suicide, not successfully suicide. In the field of thanatology, they have taken their own life or they have died by suicide. It is not a crime. Her husband died by suicide. Her mother was Chinese. She was first generation. Yeah, she's first generation. Yeah, I don't even know if she was first generation. I think her children were first generation, but she came here to the United States very, very early. So she had one foot in the Chinese culture and another foot in the American culture, as she identified it, and she could not seem to make these integrate because her mother had these expectations of her of like, suck it up and get your life back together, get all the pieces of your life back together and move forward. And she is frustrated because she doesn't feel like she can lean into the support of her mom to get the emotional support because her grieving style was unacceptable. Now, does that make mom's grieving style unacceptable? No. But it does mean working with your client and figuring out how she's going to navigate that. We have to be very careful to not put on our Western norms onto other cultures. Okay. And how do they express disenfranchisement? They might avoid contact altogether. I've heard people talk about how after they've lost a child, their friends, if they come across them somewhere, they will completely avoid them. People who they were acquainted with, parents, other parents of children that went to your child's school. Just avoid completely. Perhaps they're not, if you don't talk about them, maybe you'll feel better. I had that with a client. The husband said that to the wife. Maybe if you stop crying every day, you'll feel better. I'm like, why don't you bring him into session? Not because I was mad, but I was hearing the disenfranchisement. He wanted her to feel better. He didn't know what to do. So if you stop crying, maybe you'll feel better. So when I came in, I did a little psychoeducation about disenfranchisement. We talked about how that impacted. He was mortified because that's not what he was attempting to do. And then he and she were then able to come to an understanding of how to support her in these times, which was wonderful. And then if he said something that she felt disenfranchised about, she would put her hand on her hip and go, you're disenfranchising me. Now she has vocabulary around it and he's going, oh crap, what did I do? What do you need from me now? How can I help? What is the best way to support you right now? Not a, why don't you think I support you? Or don't you know? Helping clients develop the vocabulary, maybe even through role play on how to utilize open-ended comments and statements and questions can be very powerful. Giving unsolicited advice. Hey, mom, maybe you should start dating. It's already been 2 years. Maybe I haven't even taken off my wedding rings yet. Making rude or insensitive comments. Somebody said to me, well, if Damien had gotten into rehab a little bit earlier, maybe he would have made it. And I was going to have my own Netflix special. That's where I was at with that statement. And I didn't know. I was like 26. I didn't know about all this stuff. Yeah, right? I know. I'm seeing people like, oh, exactly. That, anyway, I'll move on. Express these inappropriate expectations about the person's grief response. So what does this do for the griever? The grief reactions tend to be intensified, and that means including stuffing them down. If there was ambivalence within the relationship in any way, as we've talked about abortion or ex-spouses, that then might increase. Like, oh, I'm not supposed to be grieving this person. And then there might be other concurrent crises that occur. They may not be allowed to attend some kind of rituals. But then again, how many non-death related losses rituals do we have? There's no ritual for the loss of a marriage. What if it was a traumatic marriage? Then where's the ritual? Is there a ritual for a missing person? No societal support. The person is then alienated, and then the grieving remains private. And that's where the problems start coming in. So I'm going to open this up to questions. I'm going to ask my lovely facilitators with eCare to maybe take a look at the chat and see if there's any questions I might be able to answer before we take our break.
Hi, Christina. It's Taylor, just stepping in. Are you able to see the questions that came through?
I am, but I wasn't, I mean, there are a lot.
Yeah, there are a ton. So, I'll let Dan and Nika step in since this is actually my first day, but let's
Oh,
just yeah, so this is a great
to break you
webinar
in.
here. Someone asked, what are the three V's that Ted had mentioned? They missed the last one.
Take a look in your course pack. It's violence, volition, and violation.
Okay, perfect. Someone asked, how do we know that grief doesn't respond to medication? Was there a study done?
Oh, there's been a tremendous amount of studies done, significant amount of studies. Okay, first of all, can't really treat separation anxiety, not being able to make sense of something that has happened. You can't stop intrusive memories per se. You cannot treat, you cannot help facilitate a continued bond. You're not going to impact shock if that's usually associated with traumatic grief, for example. Um, Different parts of the brain light up if you take a functional MRI. If somebody is bereft versus somebody who is depressed, or even in prolonged grief disorder, different parts of the brain on a neurobiological level are actually lit up. So giving somebody an antidepressant, for example, who is not depressed but is sad and grieving doesn't even work on the right part of the brain. What we also know is that, if there is depression and anxiety that is co-occurring, which it certainly can be, absolutely, that medication can help mitigate the depressive and anxiety symptoms, but it is not going to resolve the issues around the prolonged grief. It's not going to help the person stop avoiding things. It's not going to help the person not be jealous or angry. It's not going to make them move towards aspirational goals per se. It might provide a little bit of energy. Another thing that's a problem is that because we're in a pill popping society, it may lead the person to go, oh, this is going to make me feel better, and not even work on additional coping skills. Maybe not seek professional support if those medications aren't working, but rather they go and get a different medication. We do know that there's some research going on right now about prolonged grief and the intrusive memories that may come with prolonged grief that are actually associated more with the addiction section of our brain, our nucleus accumbens. And so if you think about the rumination that comes over and over and over again with people who are bereft, especially with intrusive memories, they're looking to see, does that have something also to do with where neurotransmitters are dumped into that part of the brain. So every single time it goes around into the ruminative cycle, that it's almost an addictive property. But that's very new research and probably linked up to quite a bit of pharmaceuticals, and I'll get away from that comment right there. Let's see, what else do we have? You're gonna see a little bit more when we're talking about, like, it's not going to change the fact that the person is not able to integrate that loss into their lives. So no, an antidepressant, hands down. Especially, we already know benzodiazepines don't work. We know that tricyclic antidepressants do not work. Now, look, if the person isn't sleeping, we might want to think about a temporary help with that. If the person had a pre-existing condition, such as bipolar disorder, depression, anxiety, I'm not saying take off that, get them off that medication. They're depressed, now something happened and now we don't need to worry about that. No, of course you keep them on the medication. You don't want to do that. And you want to see if it's co-occurring. The risk factors associated with think about how many people you have been working with that are taking an antidepressant and they're not noticing that there's any kind of remission, remitting of the actual grieving process themselves. Some research shows that it suppresses the grieving process so much that if they go off the medication, what happens? Oh, it's all going to come out. I have stories about it, one story after another. All right, what else we got?
All right, so this is kind of going back to the beginning, but what would it mean if you're caretaking for a parent that didn't take care of you as a child and was a huge part of your grief?
Uh, what would it mean?
Yes.
How to answer what it would mean. I wish I understood what they mean by what do you mean? I mean, obviously there's ambivalence in the relationship. I've seen this. I've got a client. I have a client in mind exactly who was completely emotionally neglected when she was a child. And I've been working with her for a while. Anyway, I won't get too much into that because I want to come back to that later. But when her mother got older and needed a caretaker, she ended up moving into my client's home. And she didn't want to take care of her. But she had this sensibility, like that's what I'm supposed to do. And when her mother passed, the attachment bond was so disrupted from the ambivalence of their when she was being brought up with the neglect and abuse that the loss didn't disorganize her life as much as someone who she would have had maybe a more secure attachment with. People with secure attachment actually grieve in a very normative way. When we're looking at insecure attachment styles, such as anxious or preoccupied, dismissive or avoidant, or disorganized attachment, that they tend to fare less in integrating that loss. So think about what attachment style there was there and think about the ambivalence in that relationship. So then and here's another thing, just as I'm thinking, you can grieve the parent you never got. You can grieve the parent you wish you would have had, who maybe didn't abuse you, or who did not disappear, or did not, you can grieve the family you didn't get. So again, we have to remember loss is not just this one event that happens. There's all of the assumptive world dynamics that we have to look at. That includes what were the relationships like with your family of origin. I hope that answers that person's question.
Thank you. All right. We still have some time for a few more before the first break. So this comes from someone who is a mental health co-responder. How can we distinguish between traumatic grief and PTSD in law enforcement officers when so many of the symptoms overlap?
That is a really, really good question, and one I could do an entire presentation on.
Well, maybe we'll have you come back.
Okay, I'm not going to answer. I'm kidding. We actually have a person that one of the psychologists who work for me, she specializes in working with first responders. That is an entire unique field of individuals who are experiencing trauma on an almost daily basis or threat of trauma on a daily basis. So in terms of chronic PTSD, there is a tremendous amount of overlap, right? I am not a specialist in working with first responders, so I don't want to jump the gun and say I have the ability to understand the unique dynamics of working with that population. Making a differential diagnosis between prolonged grief disorder, which often comes with traumatic grief, and PTSD, there you should have if you don't have the charts, let me know, but there should be a chart when we're talking about like a traumatic loss, for example, you may be talking about somebody that you are that you have a relationship with. And then with somebody with PTSD, it's an experience of having another person's life witnessed as like the person's life being dead. Or, for example, the people who were first responders in 9/11 and the collective trauma that they experienced, not only their individual trauma as well. So the overlap, and I would love to be able to say I know all the differences between the first responders is it's going to be hard to distinguish between the two. I mean, ultimately, how is that person functioning, and what are the specifics in regard to the person's as a first responder? What are they coming up against over and over again? One thing I will say, and I just as a little side note, people who are first responders are often asked to like shut it down. I am a former military wife. Your allowance of expressing your trauma, you know, we know suicide rate is higher with those from the military, for example. You have to shut that down in a lot of cases so that the people around you still have faith that you're able to move into your role. And if you are traumatized and bereft, can they count on you? That becomes the question. So you'll often find people pull away. It's getting a little bit better now in terms of treatment, being open to treatment, but there is a lot of stuff being shoved down. So it might also impact the differences, might include also the social support you're allowed to have. I wish I had a better answer on that one.
No, that was very helpful. Thank you. Do you want to do one more before we take the break at 11:30?
Yeah, we have 5 minutes, and I know normally I'm the one kind of going through these, but with this many people, I'm not able to do
No,
it.
not a problem. I appreciate you bearing with me. What rituals are helpful in traumatic loss?
You're going to hold off on that until we talk about interventions, because my whole
Okay,
dissertation is on the use of rituals. So you're singing my song, but we'll come back to it later on today.
perfect. And then someone asked, what is your podcast called?
Phoenix Rising with Dr. Z.
Phoenix Rising with Dr. Z.
You
Okay,
can put Phoenix Rising, but that's going to come up with a lot of different things. It's Phoenix Rising with Dr. Z.
sure.
We have
Let
time for one.
me see if I can find another question. How do you piece apart grieving style or avoidance? I have worked with a few people who have worried they aren't actually grieving.
I wish I could ask some follow-up questions to understand a little bit more about what she or they were referring to. Can you ask the question again?
How do you piece apart grieving style or avoidance? I have worked with a few people who have worried they aren't actually grieving.
All right. While I don't fully, I think it means to parse it apart. And so there's grieving styles that you can evaluate. All right. And you do have tons of evaluations in your course pack. But when we're talking about different kinds of grieving styles and avoidance, I wonder if this will answer your question. All right. When we're doing an evaluation, an ongoing evaluation, you're going to want to look into, are they more intuitive grievers or are they more instrumental grievers? An intuitive griever wants to talk about the loss, lean into the loss, be with the loss, express the loss. The person's going to want to perhaps engage in community activities in which they are able to grieve with one another. I run a grief group right now. And that grief, I have people there who want to be able to lean into their grief. But then there's instrumental grievers, people who do things. They pull the pieces of their life back together. They focus on restoration-oriented tasks, such as who's going to do the laundry, who's going to mow the lawn, who's going to be the primary breadwinner, who's going to get the kids to school, who's going to make meal. Do you see what I'm saying? But also, I'm going to focus on this is what my life is like now, structurally. All right. That's a continuum. And when you're working with somebody, you take a look at their continuum. Where are they on that? And that's with a little bit of, with experience and maybe a little bit of supervision, you begin to become more aware of where they are on that continuum. Now, somebody may come in and I'm like, oh, wow, they're really, an intuitive griever. But as I am working with the individual, I'm noticing, no, they have a bit of a balance here. We talk about oscillating between a loss orientation and a restoration orientation, and that the combination of the two actually surmount a crisis better. That's actually based on cognitive stress theory. There's an oscillation between the two. It's not even. Okay. Now, I have had people come in. I've worked with, I'm actually working with a couple people right now, and they do tend to be males, because in our culture, males are gender socialized to not be expressive about their grief, and women are gender socialized to be more expressive in their grief. And yes, am I aware that there is a fluidity in gender? Yes, but I'm talking about in general. Okay, bear with me. I've had people come in and say, I'm a very pragmatic person and I've just been focusing on getting my life back together, but I think I'm supposed to be feeling things and talking about it, but I'm not. But then when I start talking with them, they might be some of the first people that are expressing their sadness. Perhaps they're crying. Perhaps they are expressing their anger. And I do not shut down anger. Anger is not a secondary emotion. Anger is anger. Might there be other things in it? Yeah, but look at all the other things: guilt, regret, et cetera, et cetera. So there might be a lot of feelings, behind that. And I don't challenge that. I just point out, I'm noticing that you're expressing some emotions right now. Do you have words to describe what those are? I have the other client that I'm working with who's very pragmatic, intellectualized. And I'll say something along the line. And then he was like, oh, okay, well, we talked about somaticizing your reactions. If you look in your course pack, you'll notice I break down grief reactions into 7 different domains. And one of those domains is the physiological, lack of sleep, that kind of thing. This person expresses it in a very intellectualized way. And then we started working towards, where are you experiencing that in, right now? He's like, well, I'm noticing that my stomach is really tight. Well, tell me a little bit more. Can you describe that to me, etc. He has Thanksgiving dinner. Now, his wife has just been, she hadn't even been passed away for a year yet. He and the family have Thanksgiving all together. She used to be the one that made Thanksgiving. The next day, he got sick. He felt very tired, fatigued. I know we're at 11:30. I'm almost done. He very tired, very fatigued. He's like, I called around to see if anybody else was feeling sick to their stomach, because I was thinking maybe this is food poisoning. And I was like, what if this was grief? Because nobody said anything about the fact that your wife was not there. Nobody talked about it. And he sat there and he thought about it. We talked about Christmas and the fact that he was going to have a family dinner then, but maybe he could have a conversation with his children. This was his idea. Have a conversation with the children about like really bringing her into the holiday, setting her a place setting and making her some of her favorite dishes. And he goes, and I didn't get sick afterwards. And he's able to dive into that. So while I know that we're not talking about treatment of it, what I'm saying is you can see it in the person's behavior. If they're avoiding altogether, that's a whole other thing that we're going to come to a little bit later in today's presentation.
All right. Well, thank you for giving us such detailed and thorough answers. We are going to take a break until about 11:45. Nika or Dannon, if you could step in, and I'll let you take it from here.
We wanted to throw you in there, Taylor. Thank you so much. And Christina,
Of course.
thank you. We are headed to break, as Taylor said, everybody. So we'll come back, since we ended at 11:32, we'll come back at 11:46. Give ourselves that 15-minute break. And as you are on break, if you have questions about your certificate for CEUs, feel free to let us know in the Q&A. We're going to be answering questions, but please do get up, stretch, take your break while you're here. I'm going to share my slides real quickly, and we do want to invite those of you who have not purchased our $97 for 9 CEs today, we are inviting you to sign up. The registration link we're going to put in the chat box for you. Let me open that up and I will put it in for you all in just a moment. And Christina, you're good to take a break as well if you'd like, unless you have any final comments you'd like to make.
I'll see you guys in about 15 minutes.
All right, thank you. So let me grab that link for everybody and I'm going to go through this. So today we are offering a full 6-hour recording. So if you're here already, which most of you are, we're offering this 6-hour recording as well as the Trauma and Loss in Session Clinical Response Guide, and then an additional free 3 CE bonus ethics course. So I've just put that link in the chat for you. We do have questions that we get asked quite often. So let me get back here. I've got a lot of different screens going on. All right, so why should I get CEs today? You've already committed to this 6-hour masterclass, so you might as well walk away with your CEs, and you can get the bonus guide right away, so it will be sent to you via email. All right, so if you have questions about this, we're going to be opening up questions. Let me pull up the Q&A. There are over 1,000 of you here today, which we're so grateful for. So we're going to get to the questions as much as we can, but we do ask that you try to listen in so you can get the answer that you're looking for, because a lot of you will ask the same questions, so we want to make sure you hear them. Okay, pulling it up right now and scrolling down. Deshauna will not get any CEs if we don't purchase the additional CEs. So if you have purchased the pre-webinar rate, Deshauna, the pre-webinar rate was $67. If you've already purchased that, you don't need to purchase anything additional. If you have not purchased anything at all, then yes, the rate will be $97 for the CEs. All right. Tori, where would I access the